The American Indians and Alaska Natives have maintained much of their traditional culture. Some, especially the older people, speak little or no English. They are among the most impoverished of the U.S. population and often live without life-serving necessities such as good nutrition, safe water supply, adequate waste disposal facilities, and other amenities which are considered essential to the good life. Many reservations and Indian communities are located in isolated, rugged areas where climatic conditions are often very harsh. This situation, coupled with periodically impassable roads, make transportation most difficult. In many areas of Alaska, roads are even non-existent, requiring the ill or injured to be airlifted to health care facilities. Members of the more than 500 federally recognized Indian tribes and groups live primarily on federal Indian reservations and small rural communities. The majority of the 32 states in which Indian reservations or communities are located are in the western half of the United States. American Indians and Alaska Natives, like other citizens, benefit from public health programs intended to improve health care for all Americans. Members of federally recognized Indian tribes and Alaska Natives are also eligible for health services provided by the Indian Health Service. The federal government's responsibility for the more than 1 million American Indians and Alaska Natives has a long history, originating from treaties dating from 1784 and further established through laws and legislation enacted by the U.S. Congress. A number of different agencies have been responsible for Indian health care, beginning with the War Department in 1830, the Interior Department in 1849, and finally in 1955, the Department of Health, Education, and Welfare, later changed to Health and Human Services, the department currently responsible for the health of American Indians and Alaska Natives. In August 1954, the 83rd Congress passed Public Law 568, called the Transfer Act. And in 1955, federal responsibility for services to American Indians and Alaska Natives was transferred from the Bureau of Indian Affairs, BIA, Department of Interior, to the newly created Division of Indian Health under the U.S. Surgeon General of the Public Health Service, Department of Health, Education, and Welfare. Since 1955, the Division of Indian Health has been retitled the Indian Health Service and has been a bureau in a number of public health service agencies over the years. However, the Indian Health Service became an agency of its own on January the 4th, 1988. During this period of time, 1955-1990, 35 years, the Indian Health Service has had 5 directors, all commissioned officers of the United States Public Health Service. Today, during our historical perspectives, directors of IHS, you will be introduced to each of the directors and learn of their impact on making the Indian Health Service the dynamic healthcare program and system it is today. My name is Dr. John G.Todd, retired Public Health Service Commission Officer from the Indian Health Service after 24 years of service with the Indian Health Service. This morning I consider it a real honor and privilege to be the moderator of Historical Perspectives, Directors of Indian Health Service. For I've had the privilege and honor of working with each of these 5 directors that you will see today and the impact that they have had on the delivery of health care for American Indians. I trust as you view this orientation program that you too will have a sense of honor and be proud to have served with the American Indian and Alaska Natives and the dynamic health professionals that you'll find in the Indian Health Service.
Dr. Ray Shaw became the first director of the Indian Health Service when the health program for American Indians and Alaska Natives was transferred from the Bureau of Indian Affairs, Department of Interior, to the Public Health Service as a result of congressional legislation PL 83-568, or the Transfer Act of 1954. Dr. Shaw was trained and educated in internal medicine, cardiology, and was a Public Health Service commissioned officer with a number of interesting and varied assignments. Ray Shaw, being an individual of great dedication and tenacity, coupled with a superb knowledge of public health programs and endeavors, set out to change the health status of the American Indian and Alaska Native population. He made a tremendous impact on the health status of this population during his 7 years as director. Ray Shaw retired from the United States Public Health Service in 1962 with 30 years of service and currently resides in Tucson, Arizona. He continues to maintain an active interest in health endeavors through his association with the University of Arizona Medical School.
Ray, you were the first director of the Indian Health Service, 1955 to 1962. This was a 7-year span, and I believe you was even involved with the Indian Health Program even before you became director. Why don't you give us some insights into the early days of Indian health care, and especially the next 7 years as director of the Indian Health Service?
And in the early 1800s, starting in 1801, the occupation forces, the United States Army, in other words, the doctors responsible for the care of the Army personnel provided some limited services to the Indian population surrounding the Army bases. It was primarily a matter of, at that point in time, of vaccination for smallpox. This was expanded in 1831 because of a very severe smallpox epidemic, which killed in toto well over 100,000 Indians. So that they vaccinated Indians in much larger numbers, reaching out somewhat into the surrounding reservation where such units were located. And this, as far as smallpox was continued, was more or less continued. I think we should point out, though, that the Army had full responsibility for such care as was delivered from the beginning until 1846 or 7, as I remember, where it was transferred along with the federal authorities for the western lands to the Department of Interior. So that in 1846, the Department of Interior became responsible for such health services and other services to the Indian populations thereon. Today, the Indians live in every state in the Union, but the federal reservations, I would point out, are essentially all west of the Mississippi River, and particularly in the northwest and the southwest. Alaska being in the group, but somewhat separated therefrom. The Department of Interior, with pressure from Congress, I might add, about 1870 built the first hospitals for Indians. It had been preceded by a hospital for the Menominee tribe in Wisconsin, and for one of the southern groups, I've forgotten at this point which one, but there were two of them. And then the development of the boarding school for Indians, they constructed hospitals along with a boarding school for the care of boarding school students, basically. And by 1876 or 7, there were some 5 such hospitals. At that point, the health organizations, with their pressures on the government, forced them to give health further considerations, and between 1880 and the early 90s, approximately 30 or 40 hospitals, I've forgotten the exact number, came into existence. Now, in general medical terms, they had the name of hospital, but it was a very limited type of service which was provided and was focused primarily on tuberculosis and basically the infectious diseases generally. This continued for approximately 2 decades, up to 1910, when it was generally recognized that the Indian populations had a very, very high incidence of blindness, which medically was determined to be the high incidence of trachoma. And the Congress at that point in time provided money, I forget the amount of money, it was a small amount, 90,000 as I remember, for the U.S. Public Health Service to make a trachoma survey. And the U.S. Public Health Service at that, in 1909, held a rather extensive survey and reported on their findings in 1911. About 10 years later, at which time the Secretary of Interior was named Work, and he was a physician from California. And using physician's eyes and looking over the general problems of the Indians, which came under his overall responsibility, and being aware of the original Public Health Service report, individually requested and received from Congress a law that required the Department of Interior, the Bureau of Indian Affairs, to accept a senior public health service officer to be on their staff and advise on health matters. And this took place in 1921. So from 1921 until the day of the transfer, Interior and the Bureau of Indian Affairs had the advice and guidance of a senior public health service officer assigned to them. This, I might say in summary, although the advice was given, it was seldom followed, because the physician in this position was an advisor and had no operating authority. And from my point of view, dealing with these problems at a somewhat later date, this was crucial, because the Department of Interior is the department responsible for the management of things rather than the management of human resources. And their decisions were made on that basis. Health programs require continuity, advanced planning, and acceptance. the management of things such as coal mines or forests or lumber or mining, etc. You can make a decision today to do something and cut it off tomorrow and wait 10 years to pick it up again. And that basically was the approach to the health problems. And they were completely overshadowed by the supervision and operating responsibility of people caring for things rather than people. This, over a period of time, and I might say that I knew several of these early directors of Indian Health on loan to the Department of Interior, Bureau of Indian Affairs. There were 4 altogether, up to and including myself. I went over in late 1952 and served there until the transfer occurred in 1955, at which time we brought the program back to the Public Health Service. I might just add at this point my own evaluation and experience as an advisor in the Bureau of Indian Affairs. And with the local superintendents having full control not over employees but all the funds appropriated for Indians, regardless of what program they were basically appropriated for, also resulted in the transfer in some instances of health monies away from health programs over into other activities. I could give a few examples with a little pain, such as the diversion of money obtained for the treatment of tuberculosis being transferred from a health program over to the construction of a community Indian center for the transportation program of materials on the reservation. And I even went into a hospital which was on the record as an open operating hospital and found it occupied with Indian Bureau employees and everything from road building to forestry to education. And the health program consisted of 1 room with a part-time nurse, and yet it was still on the books as a hospital in operation and had obtained money for the purpose. So nothing, any of my experiences in the advisory position were satisfactory as far as I was concerned, and I was not against and ready to support any and all activities to improve the situation, so that my actions and advice and activities during those times were not only a very strenuous one to improve programs to control the infectious diseases within the population, but to get them in a position where sound programs and expenditure of money for health purposes could be assured, so that the Congress and their attitudes and concerns with respect to the recruitment of Indians off reservations into the defense industries, the experience with the Alaskan Army division manning the early warning stations. This resulted in the Perrin Survey of Alaska preparing report nailed down the basic health facts so nobody could really argue against them. And the National Tuberculosis Association, the state and territorial health officers, the American Medical Association, and all other health programs who had organizations and representatives joined in an effort to transfer it out of Interior over to the Public Health Service. Mr. Noble Swearingen, who was his Washington representative, and Swearingen spent full time in the halls of Congress promoting and in a sense demanding that something be done about this. And I was under continued pressure to, number one, lock it up on one hand from Interior, to carry out my duties to the Public Health Service, and my Surgeon General, and Swearingen, had the bill introduced into Congress for the transfer of Indian Health to the Public Health Service.
Ray, you have given us an excellent historical background to the early days of Indian Health, and I just have a few questions maybe that I'd like to ask you on some specific issues concerning health care for American Indians after you became the director. Then the transfer took place actually in 1955, and you became the first director of the Indian Health Service under the Public Health Service in 1955, I believe.
And we ended up transferred to the Public Health Service effective July 1, 55. As a somewhat of a parting shot through various associations I had, with a good deal of assistance from a lot of people, the bill was amended to provide $250,000 for a survey of Indian health, which would give us a basis on which to work and plan and justify programs which we expected to present. This passed and came into being about a year later.
When you became the first director of the Indian Health Service, obviously there was a lack of health initiatives, and you had to develop some health initiatives and goals and objectives. And what was the goals and objectives at that point in time?
I tried to keep them as simple as possible and to broad enough to permit a comprehensive approach. It was easy to foresee the necessity of establishing priorities. But long run, we had to have a much broader vision. So we had three major objectives in planning the program at and following the transfer. First was to provide health and medical services required to meet Indian health needs not met through other resources. The second is to promote participation in the Indian health program by the Indians and the Alaskan Natives, looking towards their eventual attainment of normal responsibility for effective management of their own health affairs. And three, to encourage state and local governments to make available to Indian citizens community health and medical services of the same quantity and quality as those available to the non-Indian citizens. Now, within that framework, we could easily provide a broad, or plan at least, a broad, comprehensive program to solve the Indian health problems.
Obviously, when you became the first director in 1955, there was a real lack of personnel, no health managers, very few health professionals. So one of the first problems you faced was recruitment of some staff, I guess. Could you give us just a brief insight into that?
Well, there was another important thing that happened that I forgot to mention, perhaps. The Health Manpower Act came into existence during the period when physicians were in very great need and short supply for service in the military, and the Doctor Draft Act came into being. At the head of that program was Dr. Howard Rusk from New York, and on his own initiative, and certainly with the help of the National Tuberculosis Association, he knew and quickly became very familiar with the existing problems among the Indian population. Therefore, the Physician Military Draft Act was amended to permit the assignment of physicians eligible under the draft to be assigned to the Indian Health Program.
Ray, and some of the stories I know that went around in the early 50s, mid-55, soon after you became the director of the Indian Health Service, I believe, was that the Public Health Service wasn't that excited, the rank and file Public Health Service people, about being in charge of the new program, Indian Health Service. And it even became known that if you sort of messed up someplace in the Public Health Service, you would be banished to the Indian Health Service as the next assignment. Was that really true in those days?
Yes, that's why I went over there. I should say sent over there.
I think it would be interesting to know organizationally how you set the program up in order to have some degree of management and expertise in managing the program from, let's say, the Washington level down to the area level and on to the grassroots level where the Indian people really live. Could you give us a little discussion of that this morning?
Well, from analysis of the multifaceted problems of culture and language, isolation, education, economics, local availability of services, housing, transportation, water supply, sanitation, and local attitudes, it was clear that the program would have to be tailor-made for each local situation. Accordingly, the problem was approached from a geographic service area point of view and developed so as to provide comprehensive services for a geographic area rather than for a single specific area, because the problems were such it varied from place to place, so that we basically set up a service area for the reservation, specific reservation concern, which included a large general, not necessarily large, but a general hospital with broad services for health care of all types. This was, in turn, the base for support for smaller community-type hospitals, up to, say, 50, 60 beds or less, for the general practice type of health problems that they could handle scientifically and satisfactorily at that level. Anything that required more definitive type of workup or services were referred to the larger hospital base, which was always within 100 to 200 miles at a maximum. Out from the smaller community-type hospitals. We established health service general type of operations for daily visits, for outpatient care, for public health programs and educational activities of all kinds. And beyond that level of operation were the visiting nurses, the isolated clinics manned by a trained physician, health visitors, sanitation aides, and so on, to work directly with the people.
Dr. Shaw, I'd like for you to give us just a little bit of your insight as to how the Indian leadership and the individual Indian people viewed this new Indian health service that was responsible to provide health care for them.
Well, I must say that my evaluation of it was one of immediate success and acceptance, generally, of the, quote, new health program. The sanitation program and our initial and continuing effort and extensive work in working with the tribes, with the medicine men, developing a basis of mutual understanding and approach, worked exceedingly well and was fortified very quickly and continuously at all levels by the success. For instance, they weren't losing as many babies.
Dr. Shaw, I know during the past 35 years you've seen a lot of things come and go with the Indian Health Program and the delivery of health care and services to the American Indians and Alaska Natives. And we certainly appreciate you taking the time this morning to give us some historical data on how this program was first developed and laid out to raise the health status of our first Americans.
Thank you.
Dr. C.J. Wagner, an orthopedic surgeon, became the second director of the Indian Health Service in 1962. Dr. Wagner, known as WAG, came to the Indian Health Service directorship from the Office of Health Mobilization. Dr. Wagner had a major impact on the total Indian Health Service and was responsible for many changes and improvements in the management, operation, and delivery of a comprehensive health care system for American Indians and Alaska Natives. Dr. Wagner left the Indian Health Service in 1965 and became the director of the Bureau of Medical Services, and continued to have an impact upon the Indian Health Service program since it was a program under his authority as director of the Bureau of Medical Services. Dr. Wagner was responsible for the Indian Health Service's involvement with a number of Peace Corps training projects, as well as a number of U.S. aid projects, such as Peace Corps Korea and the Liberian Project for the John F. Kennedy Memorial Hospital in Monrovia, Liberia. Dr. Wagner retired from the Public Health Service in 1968 with 30 years of service. He currently resides in Sacramento, California, where he's associated with the California State Health Department.
Dr. Wagner, in 1962, you became the second director of the Indian Health Service, a program now 7 years old. Many changes had taken place since the days of the BIA. Why don't you share with us today some of the major program initiatives that you felt necessary to advance the Indian Health Service and the care for the first Americans during the years you were director?
And it's very difficult for a director of anything to define that he has this need, he has this amount of resources, he's going to do these things and not do these. Because as soon as he says he's not going to do these, he's then defining, so he's making a choice between people who are going to get services and people who aren't going to get services. To handle this, what we thought was absolutely necessary was to come up with a management process which would create a force in being which was mission-oriented, and which we could use a new approach to management in the health field, and that is the actual introducing a process which was self-organizing and would then have a multiplying effect. We developed that prior to the time and were successful in getting the American Management Association to accept it as a part of a program that they were incorporated in what was called the President's Course, which was directed to the heads of corporations, where the primary emphasis was upon how do you do corporate management and the chief executive officer type of function, but also we were able to include for the first time a health approach, which was based upon the process. Now, the principle of the process was, as Ray had pointed out, is not something that a physician normally has when he finishes medical school, nor, to a large extent, public health nurses or public health trained people have. They're trained primarily, the doctor is a problem-oriented professional. When the patient presents himself with a problem, their primary purpose, as they see it, is to solve the problem. The public health people are primarily trained to be consultants, to obtain grant monies, to set up demonstration projects, to come up with the operators in the public health service, primarily, in the perfect example, the professional sanitarian is trained to be an operator, to get things done, to get planned things done, and to get things done through other people. And he's trained that never is it an easy thing, even though he knows the best way of doing a thing, to get the best way of a thing introduced the first time he tries. He's trained that management is the ability to compromise fundamentals to achieve a desired result. And he learns to make a wise alliance with circumstances when he wants to achieve something. So our first effort was to come up with a management program that would change the way the physicians and all of the health workers that made up the Indian Health Program approached the problem of developing and implementing and achieving an elevation of the health status of the demographic group it was serving.
So, Dr. Wagner, actually, when you became the second director in sort of an assessment of the program at that time, you felt there was a need to have better trained managers. A physician as a physician, a healthcare provider certainly was there, but you needed some better management stability, and that's when you sort of got hooked up with the American Management Association. And what level did you have, middle managers, area directors, or who went to that program then?
You know, well, you see, it wasn't so much a matter of better management. It was a different kind of a management. It was the ability to work, you know, as a part of a team, rather than the way we were trained to be just you're a physician taking care of an individual patient. You become a manager of getting things done and getting planned things done, and you're getting them done through the beneficiary. The beneficiary is really the one who does the work and takes care of all of his needs under a comprehensive program.
Well, what was your priority? Who did you first send to the AMA programs then?
Well, the primary person that we wanted to get was the area directors, you know, so that they knew what we were trying to do and were sympathetic to it. And so we had a great deal of contact with them.
I believe one of the things that you really became involved in fairly early on after you became director was looking at an assessment of the overall training needs of the total staff. And I believe as a result of that, why during your tenure as director, why you set out to establish in each area a training officer.
As you know, we picked primarily sanitarians, and the reason we did is because the sanitarian of all of the health professions, I think, are the people who have the ability to see a need and to do something that that influences a person that is necessary to meet that need, and to do it in such a way that he sees the need and really believes he saw it himself for the first time without anybody telling him, and that he looked at the various alternative way. He went through the process, in other words, of how to handle that need, and then was very proud that he came up with a method of doing it. And this was the idea that of the training office. He had to go into the office. He had to organize the office around the training plan and do it in such a way that they really felt this was their own very mature approach to a very serious problem that they were responsible for solving.
Actually, then, Wag, what you became involved in was the program planning, budgeting, managing concepts of the program. Then I would assume as a result of this process, where this sort of resulted in better or more program accountability of what was taking place in the Indian Health Service during those days.
Oh, tremendous, yeah. Really, the important thing about the accountability is that they realized the accountability wasn't something that they had to fear from headquarters. The only reason accountability was identified as a very valuable thing was because they identified from an accountable standpoint what was happening as against what they planned to happen, and it was a part of the process and not a part of some regulatory or some, it doesn't affect promotions, it doesn't affect status, it doesn't affect recognition. It was a tool of management, not a tool of measuring people against some standard.
Dr. Wagner, I believe then you sort of looked at the need maybe to become a little bit more public health oriented than clinically care oriented, and even this resulted in the establishment of field medical officers, if you will.
I really felt that public health people are trained, not as operators. They're trained as consultants, as advisors. Action is not their forte. They're people of contemplation and mild regret, So what I tried to do is say that what we meant by elevating the health status is that you assured in your program that at any point in time you were applying the state of the art in prevention of disease. And the state of the art in curative services of those things the state of the art couldn't prevent. And the state of the art at containing at the lowest level of disability those things you could neither prevent nor cure. In other words, there was there wasn't no such a thing as direct medical care separated from public health, because the individual was a very complicated process, and he had some things that required medical care. He needed some problems that needed containment at the lowest level of disability, and there were things that he had to be prevented. The infectious and contagious diseases primarily were pretty accepted and pretty well handled, but the other prevention is first the diabetes, which was a very significant health problem in many of the tribes, the cardiovascular things that were developing and it could be anticipated. All of these things we were trying to come up as being the equal responsibility of the single individual who first encountered a patient, that every time he encountered the patient, he was encountering a very complex thing, and he had a very complex program that he was trying to initiate with that patient. And I wasn't trying to change clinicians into public health people or public health people into clinicians. What I was trying to do is create a mission-oriented force in being where various specialties were working together towards a common goal that couldn't be achieved by any one of them individually.
Dr. Wagner, I believe that you were involved in the establishment of a number of Indian health committees as an arm, if we might call it, of like the American Association of Pediatrics and the American College of OBGYN, and I believe there was ASTHO, Association of State Health Officers, and can you tell us a little bit about how you envision these committees would function with the Indian Health Program and this sort of thing?
It wasn't truly deceitful, but our purpose was primarily to get people who were recognized nationally as a part of the operation, with the idea that if at first they're very critical and very sharp people, as you know, that if what we were doing, we were just fooling ourselves, they would make sure we knew it. But if we were doing something that I thought was revolutionary and very worthwhile, that they couldn't not come and not become addicted, you know, and they did. The American Academy of Family Medicine, as soon as we came up with the concept that there has to be a manager of health services and that this ought to be a generalist, and that the ideal person for that is the family physician, because he's the man who really has the responsibility of seeing to it that the health status of the family as a group is elevated. And they thought that was not only right and could be handled, but they even went ahead and set up a committee, and they even got some grant money, and they actually went out in Virginia and a couple other places and set up models under a grant to see how it operated. And then, since the automated medical record that one of our people had developed and published as a book came out about the same time, and Larry Weed's health problem thing came out, some of the initial things that they had in developing the database on these people was based upon that. Because of the tremendous problem that the Indian health people had with infant mortality and with some of the OB pregnancy-related complications, of course, the American College of Obstetrics and Gynecology was a very significant one. And we brought in those people, and they set up a committee, and they would go out on the reservation. They did a lot of training, first directed at clinical medicine and that type of thing, but also were being exposed, you know, to comprehensive care.
Dr. Wagner, I believe after your tenure as director of the Indian Health Service, you was promoted to become the director of the BMS. In those days, that was called the Bureau of Medical Services. And the Indian Health Service was a division in the Bureau of Medical Services, so you still had an influence, an impact on what was taking place in the Indian Health Service, with Dr. Ribot now being the director of the Indian Health Service. And I believe that a couple of program initiatives that came about as a result of your working with Dr. Ribot was the Indian Health Service became involved in a project in Liberia. Actually, the building, development, and early management of the John F. Kennedy Memorial Hospital in Monrovia, Liberia. And a second initiative that came about while you was director of the Bureau of Medical Services was the Indian Health Service became involved in Peace Corps training projects, and particularly the early one was Peace Corps training for Korea. And would you share with us a little bit of how these two initiatives had some impact on Indian Health Service and the professional development of people?
Yes, the Liberia one was a very beautiful example of taking a program which was very successful, the Indian Health one, and using it to model, you know, using a base hospital, the health centers and the health stations and the various outreach people and this type of thing, that really became a very good demonstration of this that has now come back to the United States, and private hospitals have adopted it also. You know, even the Joint Commission on Accreditation of Hospitals adopted the outreach program concept and measures hospitals against that. The Peace Corps saw, I think, this as a wonderful opportunity to teach, to give a much more comprehensive background to the people who were going, the health workers that were going out to some of these emerging countries and so forth. And we got a lot of feedback from these that were trained and came, and as you know, we sent a delegation down to Ecuador, and they used the concept in developing their national health care system. So a lot of these things were spun off, and the effects were felt, and much of it, it became a real process that was self-organizing and continued to have a multiplying effect, and its origin was lost, in the process.
Dr. Wagner, I want to personally thank you for taking the time to be with us today and sharing with us some of the activities and initiatives that took place when you was director of the Indian Health Service and led this program along the road to the 35 years of history that it enjoys today.
I thank you very much for having me.
In 1965, Dr. E.S. Rabot became the third director of Indian Health Service. Dr. Rabot, known as Stu, was a surgeon by profession. He brought a vast amount of knowledge and experience of American Indians and Alaska Natives to the top management and administration of the Indian Health Service. He had served in Nome, Barrow, Tanana, and Kotzebue, Alaska, hospitals for a number of years before the Transfer Act in '55, as staff physician, medical officer in charge, plus a variety of other duties at a remote outpost of the Indian Health Service. From Kotzebue, Alaska, he moved to the Alaska Area Office in Anchorage as the clinical director of the hospital and then as the deputy area director. In 1960, he moved to the Bemidji, Minnesota sub-area as chief medical officer and deputy area director. He was transferred from Bemidji to Aberdeen, South Dakota in 1962, where he became the Aberdeen area director. He remained as the Aberdeen area director until 1963, when he was transferred to the Indian Health Service headquarters office in Silver Spring, Maryland, to become the deputy director of the Indian Health Service under Dr. Wagner. In 1965, he was appointed director of the Indian Health Service. In 1969, Dr. Rabot stepped down as director of the Indian Health Service and moved to Tucson, Arizona to become director of the Indian Health Service Office of Research and Development. Dr. Rabot remained as director of the Office of Research and Development until his retirement in 1981 after 30 years of service as a Public Health Service commissioned officer. Upon retirement, Dr. Rabot returned to Alaska and became deputy director and director of the Alaska State Health Department, where he remained until his untimely death in May 1984. Dr. Emory A. Johnson, a family practice physician from Minnesota, came into the Indian Health Program before the Transfer Act of 1955. He came into the Public Health Service with the thought of staying for a 2-year obligation and then getting out. He did get out, but some 28 years later. In 1969, Emory became the 4th director of Indian Health Service. He remained as director until 1981 and served the longest tenure of any Indian Health Service director, 12 years. Dr. Johnson entered the Public Health Service and was assigned to the Indian Health Program previous to the transfer from the Bureau of Indian Affairs. He served as a reservation staff physician in Winnebago, Nebraska, and White Earth, Minnesota. He also spent his entire Public Health Service career associated with the Indian Health Program. He had a number of interesting and varied assignments, such as the Billings Area Director, Director of the Phoenix Indian Medical Center, Chief of Program Services at Indian Health Service Headquarters, Deputy Director of the Indian Health Service, and then Director of the Indian Health Service in 1969. His efforts over the years have indeed placed Indian leadership in a posture if they desire to take over and manage their health care delivery systems and programs. Dr. Johnson retired in 1981 after a 30-year career as a Public Health Service commissioned officer. He currently resides in Maryland and Virginia and is active in a number of projects concerning Indian tribal activities, legislation, and health care services.
Emery, you were the fourth director of the Indian Health Service, 1969 to 1981, some 12 years, and the longest tenure of any director in the 30-plus years of the Indian Health Service. I know you have spent your entire professional career with the Indian Health Service in all aspects of the program, service unit, area, and headquarters, and was even in the program before the transfer in 1955. You must have seen many changes in the Indian Health Service over the years, and especially during the 12 years you were the director. Why don't you share with us some of these changes and initiatives that came about during the time you served as director?
Well, John, I'll be glad to do that, but first, if I might, I'd like to sort of put the program into perspective. I think it's helpful for us to know where we are, to know how we got here. And I can go back to the day before the transfer when I arrived at White Earth. And at midnight, we transferred to from the Bureau of Indian Affairs to the Indian Health Service. And so the first few weeks, months probably of my career, we still had a lot of the hangover behavior of the Bureau and some of their rules and regulations. We had such a pitiful clinical circumstance. In that first hospital, I couldn't even do a hemoglobin, let alone blood gases and blood chemistries and things like that, and yet we were supposed to do and did major surgery. We had no contract health services money, so whatever a patient got was what you had to do yourself. And it was easy to think in those days that the solution to the health problems of Indians was clinical medicine, the kind that I was trained at the University of Minnesota. And I had all the answers. Well, now we're what, 35 years down the road, and I don't even know all the questions. But to put in, as I now look back and understand better what we were doing, it seems to me that the Indian Health Service was blessed with a foundation that really set the course for the whole 35 years. And by this I mean, John, that for some reason or other, the Indian Health Service was not created to provide medical care. The Indian Health Service was created to elevate the health status of Indian people. And so the Indian Health Service, starting out with such dismal clinical circumstances, Dr. Shaw made what I believe is the only correct decision that could have been made, and that was that your first priority has got to be clinical medicine. There's got to be something that you can do so when a mother brings a sick baby, that you can treat that baby and that baby can go home a well child. That doesn't mean that we didn't care about prevention, because we were out putting immunizations and we were promoting well baby care and prenatal visits and immunizations and all those things from the very beginning, from day one. Tuberculosis control, that was all prevention. But the first priority really had to be on getting a solid clinical base. We established the clinical base. We then went into the second phase, as I would describe it, where we began to develop the management techniques, the more refined, the more objective, quantifiable management techniques, and the training, the concept of focused training, so that the kinds of skilled manpower that the Indian Health Service needs to carry out its mission were being created, and with emphasis always on creating that trained health manpower from the Indian community to the extent that that was possible. Well, in the mid-60s, we had a chance under the Office of Economic Opportunity to encourage tribes to start something that we ended up calling the Community Health Representative. And as you know, that is a program now that I think every tribe, as far as I know, has at least one CHR. But it was developed again for a very specific kind of purpose. The idea was that there has to be some communication mechanism between the health professional, who in those days, and still to some degree today, is an outsider, and the members of the community. And what better place to do this than to have someone from the community being trained to understand health systems and